Howdy, everybody. We're so glad to have you with us this evening for things we're longing to know and too afraid to ask. I know many of you have been here with us before, but for those of you who haven't and aren't familiar with Roots and Roads, I would just like to share a little bit more about us. Our vision is to transform the end-of-life experience into the final act of living well, and we go about that in a few different ways, one of which is exactly what we're here for tonight, coming together to learn about end-of-life issues, and we're really excited to have Tawny Body with us. Another way in which we transform the end of life is by financially assisting hospice patients of limited means for basic needs that aren't covered by health insurance. And then we also have our newest resource, which is an online resource called the Crosswalk that we launched at the very end of last year. And we've been refining it through these past several months, but really was built with the idea of bringing together resources, starting with diagnosis of serious illness all the way through end of life, including final arrangements and bereavement. So if you haven't had a chance to visit that site yet, we would love for you to look through it and give us your feedback. We would like to extend a heartfelt thank you to our sponsors. Our overall sponsor this year has been the Connie Hillman Family Foundation. And we've also been able to bring this series free of charge to folks with the great support of Pima Council on Aging, Right at Home, and Casa de la Luz Hospice. And I would just like to give a quick shout out to those individuals who donated to underwrite tonight's session. There have been so many of you, and we are so grateful for you being here and for your belief in what we're doing. Thank you for your support. It's so wonderful to be able to partner with so many different organizations throughout the community to draw on this expertise and to further the conversation. And one of our outstanding partners who's underwriting tonight's session is Pima Council on Aging. And so we are so grateful for their partnership and support, and we look forward to moving forward with them next year and in the years to come to bring more of these education sessions to our community. And with that, I would like to introduce our speaker for this evening. Tawny Body has been a nurse for over 47 years, and as you can see in her bio, she has spent most of her career focusing on improving end-of-life care, recognizing how fear, misinformation, and lack of information can negatively impact decision-making and the dying process. We are so fortunate to have her here with us this evening, and so I will turn things over to Tawny.
Understandably, there's a lot of fear out there because we're not really taught about the dying process, even in medical and nursing schools. And so for a lot of people, they feel like Woody Allen when he said, I'm not afraid of dying. I just don't want to be there when it happens. Because for a lot of people, they say, I have my own belief about what does or does not happen after I die, but what do I have to go through to get there? That's where the fear comes. And that's where I think we as healthcare professionals need to stand up and do a better job about talking them through that, because the misinformation out there is, like everywhere else, is astounding. So for example, for those of us who have been pregnant in our careers, in our lives, remember going to the grocery store and you're 8 months pregnant and total strangers would walk up to you and pat your belly. And then they begin to tell you about their 18-day labor, right? I mean, horrible birth stories. And then they'd walk away and they'd feel good. And you're like, oh my God, why did you tell me that? We have this thing about we share bad information. We share how people are in pain, how they've lost dignity, all those things. But what we don't share are all of the deaths that are just as beautiful and sacred as birth. So that's what I really want to be able to emphasize and incorporate into parts of this. Why it just doesn't like to advance here. Should I just it did this last time too. How do I advance it? Because it's not letting me do it.
Are you using your keys or?
I'm using the keys. And it's not letting me advance.
Can you do like a mouse click on the slides?
Oh, there we go. Thank you. Okay. So I love this quotation. There's nothing in life is to be feared. It is only to be understood. And so that's, I think, again, within our purview of how do we help normalize the dying process, because it is a natural process. And this actually comes from my father. He wrote, "We admire the death of leaves. Why not our own?" I mean, there's something about fall that I just love. And that's when leaves are dying. And when they're dying, they release their colors in beautiful arrays and unique ways. And so that's what we can kind of look at a life coming to closure too, is along with the grief and loss of that, there's also some beauty in a life closure. And especially if we can arrange it so that they're comfortable and make a good passage with good closure, that's kind of the key there as far as I'm concerned. So for me as a hospice nurse, it was always helping patients and facing the fears. Sometimes they'll ask me, how am I going to die? What's it going to look like? What's it going to feel like? But people don't know that they can ask that. And they're also terrified of asking that sometimes. So when I get that kind of deer in the headlight looks from them, then I will kind of precipitate that question by asking, do you want to know what to expect? And invariably, it's yes, please. And what I'll do is I'll take them through the dying process according to their particular disease process, because it's different to die of a brain tumor than it is to die of kidney failure, than it is to die of end-stage Alzheimer's, et cetera. And when I take them through that natural process of how the body shuts down, and most importantly, how to manage that, the sense of relief is phenomenal. So now they're not just stuck in their fear. Now they can put more of their energy into living the time they have left. The other reason we may need to know about how they're going to die is they may need to choose. And we touched on this the last month. So for example, I had a gentleman who'd was on dialysis for kidney failure, but he was also diagnosed with pancreatic cancer. He lived by himself. He didn't have any support. And so he was conflicted of, what do I do? So we talked about what would it be like to die of cancer of the pancreas? What would it be like to be treated for cancer of the pancreas, realizing that it was a short-term goal, but side effects, et cetera, and what it would be like to die of kidney failure. So for him, it was a choice of, oh, okay, you know what fits my needs and my values is to choose this way of death and this timing. So it's really important to understand what is a disease progression, especially if you're dealing with some comorbidities. So here's the basis of everything I'm going to talk about tonight. There's more wisdom in your body than in your deepest philosophy. Your body knows what it's doing. Just like it has to go through certain stages to be born, it's got to go through certain stages to shut down and to die. So what we look at are what are the natural and normal changes that you're going to go through that you do not want to interfere with lest you inadvertently create more discomfort. And very often that's around fluid and nutrition issues. And what are the side effects that if they come up that you do want to absolutely have treated? So, but we have to pay attention to the wisdom and allow the body to do what it does naturally and support it along the way. And here's the other really important premise, especially for you as caregivers. The person who is dying is the expert on what is and is not needed. They're the only ones inside their body. They're the only ones that know what it's like to say, I can eat this, I can't eat this, I can't get up, etc. So if we want to provide the best care, now's not the time to nag them to be in another way, but to say, this is where you are today. I will respect that because I really love you and I want your best comfort. So body's wisdom, patient is the expert, two really important parameters here. Be aware also that if you're dealing with chronic and end-stage illness, now obviously I'm not talking today about sudden heart attacks, gunshot wounds, car accidents. I'm talking about end-stage illness. That accompany that, there's a lot of changes that we're going to go through. I mean, those of us who are getting older, we're already dealing with changes, right? Each one of those physical changes is going to be perceived as a loss, and it has to be grieved by both the patient and by the family member. So allow space for that. So for example, if a woman can no longer live alone by herself, it has to move to assisted living. People go, oh, but feel good. You've got all this care and you got all this support and people are serving you dinner. Oh, and that may be true, but you know what? She's also lost her home. So let her grieve that first and then talk about what is the new normal now. So allow that expression every step of the way because there are multiple losses along the way when dealing with a chronic illness. So one of the early changes that happens with illness is simply changes in energy. And the old ways no longer work. So what I mean by that is, like, when you're sick or when you've had surgery, you have a recuperative time and you spend time building up. You eat a little more, you exercise a little more each day, you build up. But when you're dealing with an end stage illness, your body's not going to do that anymore. And that really messes you up because you think, I should be able to do this. And your family members are saying you need to eat and do more, and you can't. Because again, that's the fear. So for example, a daughter might be saying, Mom, you're used to walking around the block every day. You got to keep doing that because, I don't want you to get any weaker, because her fear is if Mom stops walking around the block, she's going to get weaker faster. She's going to die sooner. But Mom has only got so much energy. So for me, it's using really simple terms and working with the families that are really easy to understand, is to say, you know what, the energy that your loved one has each day is different. It's like money in the bank. Here's the money I've got to spend today. Here's the energy I have to spend today. How do I want to spend it? Now, if you're still fixed on the path of, hey, you got to get up, you got to take a shower, you're not going to use your wheelchair, I want you to walk to the breakfast table. By the time you get to the breakfast table, Mom may have spent all of her energy. It's gone. Now she's too tired to even eat. So inadvertently, we've worked against her. So that's why I say we've got to reprioritize now. What is it that the person needs? What is their energy level that day? Maybe somebody's coming from out of town. They haven't seen in a long time. Great. You know what? Rest in the morning so that you have the energy to really tend to them and enjoy their visit in the afternoon. So it's reshifting how we look at our priorities. The other thing is that as disease progresses, people tend to sleep more and more and more. They get weaker and weaker. Now, there's good and bad news about this. The good news is most of us say, if we had a choice, we'd rather die in our sleep. Well, how the process works is that's exactly what happens. How cool is that? You get sleepier and sleepier and sleepier until you're sleeping all the time. You go into a coma. The coma may last minutes. It may last a week. But during that time, your body continues to shut down. Awesome. The bad news for the family is going, wait a minute. These are our last hours, days, weeks with you, and you're going to sleep? I don't think so, because they're used to the Hollywood, movie scenes, right? So the first thing they often do is saying, they're over-medicated. You've got to pull back the medications. But that's why I warned them ahead of time. This is the natural process of sleeping more and more, kind of in preparation. As one patient described to me, he said, it feels like I'm visiting the other side. I wake up and I'm not sure which side I'm on at that point. But we have to, again, allow the person to dictate that. And we have this weird thing about we've got to at least get people up in a chair, right? Have you ever been to nursing homes where the hallways are lined with folks in wheelchairs and they're all kind of slumped over? Okay, and they're sleeping. That's too often what happens, and it's really taxing of the body. So I talked to the family. There's her mother lying in bed. I said, you know what? Just lying there in bed, your mother's body's working really hard. Now, a normal pulse or heart rate is 60 to 70, but her heart rate might be 100, 120, 140. I say, that's the heart rate of somebody running a marathon. So just lying there, it's like your mom has been running her marathon and she hasn't stopped once in days. Now they get it. Oh, she's too exhausted. So making her get up and do things is really far and above what her abilities are. So again, we really need to look at what is it that the patient can and cannot do, and accept the fact that their abilities are going to change over time, and it's going to create distress with the family. The other thing that starts to continue to happen is as they sleep more and more, again, they may lose a level of consciousness or ability to respond to the world. And again, the families might be very upset thinking, I'm here, I came from out of town, you're not responsive anymore. But I always remind them, hearing is the last to go, and we know that. So continue to talk with them. Maybe it's now easier time to say things that you wanted to say that you couldn't say when they were alive, but continue to talk with them. So what I will do if I'm in an inpatient setting is I will model that. I will go in and talk to the person who is maybe comatose. Maybe they've had dementia and haven't recognized anybody in years. Doesn't matter. They're still a fully intact human being, deserving of all the care as if they were totally alert. So I will call them by the name. I will touch them gently. I will let them know what I'm going to do before I do it. I'm going to roll you on your right side now. I'm going to put a washcloth on your face, etc. And while I do that, I'm going to get the family talking because this is really important. I'm going to say, what's your favorite memory about your mom? And as they recite their memory, they can't help but raise the energy in themselves and in the room. So they feel better. That helps them with their grieving and letting go. And then mom, who's lying there, maybe comatose, gets to hear about how she's going to be remembered. So kind of a win-win. So when I get them talking, I'll just say, keep telling her about your favorite times, or use music, prayer, whatever it is that you need, but use that to continue to communicate with them and to talk with them. And in addition to continuing to talk with them, again, comatose or not, continue to touch, continue to hold. Because I got to tell you, especially older folks, we don't get touched enough. People who are dying really don't get touched enough. And so we really need to spend time to say, how do we need to do it? Because this is so important. I remember I was working in a hospice and I looked in a room and there was a woman by the side of the bed of her husband of 62 years, and he was actively dying. And she had reached through the side rails and she was holding on to his wrist, and she was hurting. She was in so much pain emotionally. And I just instinctively went in there and I said, do you need to get up there and hold him and spoon him one more time? And she said, oh, yes. I said, this is your time. So we got her onto the bed. She got to spoon her husband. We closed the curtain, closed the door. She got to hold the love of her life while he was dying. What an important memory for her. And how wonderful for him to be embraced by that love while he was dying. We don't think about that with adults. We do that with mothers who are losing their babies and children, saying, hold them, touch them. But I got to tell you, if I'm 90 years old and it's my 70-year-old son who's dying, that's still my baby. And I may need your permission to climb up there and hold him and talk to him. And if you're in an institutional setting, or especially like in assisted living, let the staff know what's happening too. Get them on board. I was giving this talk in Texas once, and an attorney stood up and he said, my client did everything that you said to do. That nursing home called him and said his mother was dying. And so he came in and he climbed onto the bed and he was holding her. And an uninformed staff member came by, looked in, and called the police and arrested him for molesting his mother. So he was in jail when she actually died. And it just devastated me. It's like, this is the human part of it. We need to talk. We need to touch. We can get the pillows. We can move things around, but what an important memory. And even after death, I tell folks, and especially if you're in an institution, put the side rails down. Really, they're no longer a fall risk. Put the hands on top of the sheets, give them full access to them, and encourage the family that it's okay to touch. And if you need to go in and model it too, then I'm going to go in and I'm going to touch the person who has died, and I'm going to talk with them to make sure that they know it's okay. I pronounced a death in South Tucson once. This gentleman was absolutely adored by his family. There were 32 people, adults and children in this home, and they were all standing there rigid, and they didn't know what to do. And I said, it's really okay if you want to go in there and hug him one more time or touch him or anything. They spent the next 3 hours rotating in and out, touching him, hugging him, telling stories. And the grandkids came out and they said, oh, we got to hold Grandpa's hands. They were so strong. He used to swing us around. So again, it just helps with that closure, with that memory. So the touch is so very important. Don't forget touch. Don't forget touch. If they don't want to be touched, you're going to know right away, because there are some folks that will jump with it for whatever reason. But most folks are usually going to be quite comfortable by being embraced. Okay, changes in eating. This is where the real conflict comes in, because your ability to process food starts to go down. The ability of the liver to break it down, the intestines to push it on through. So if you start pushing food when the body says no, you can cramp up, blow up, throw up. That's not exactly what you wanted for comfort, right? But we're worried because we see our loved one losing weight, and maybe there's even a family member from the outside going, "You're not taking care of mom, she's losing so much weight." And you're terrified that they're going to starve to death, right? So here's your mantra. They're not dying because they're not eating. They're not eating because they are dying. The dying body does not need or relish food. In fact, it will absolutely complicate it. Let me give you some detail. So let me give you an example. So here's a woman, and she's on hospice, and she's not eating. Now, just because they're on hospice and not eating doesn't mean it's like, that's okay. So yes, no, and maybe. You're always still going to be doing your assessment because you want the best possible comfort care for your loved one, right? So examine the maybe first. Is the cause reversible? Because we want the highest level of comfort and function at all times. So we're always assessing no matter what, on hospice or not. So reversible things. Maybe she's got mouth pain, nausea, dry mouth, medication, mouth sores, ill-fitting dentures, depression, cognitive changes, taste changes, stress. All of those sorts of things are reversible causes for somebody to not be eating very much. So take a look at those and just see if those are being ruled out or not. Medical causes might include gastroparesis, meaning the stomach has stopped pushing the food down, swallowing difficulties, constipation, you don't want to eat, infection, abnormal fluid collection in the body, obstruction. All of those sorts of things can also cause a loss of appetite. How much you do or do not want to intervene may be very different, but those may also be causes. So the approach really for somebody who's not eating is really good mouth care. I mean, when you get up in the morning, can you imagine when your mouth is dry and nasty and sticky, if somebody started pushing scrambled eggs in your mouth? It's like, I don't have the saliva, I don't have the taste, whatever. So offer water, moisture, actually good mouth care. Don't be sitting there with the next spoonful ready to shove in, while they're still working on one spoonful. Forget the dietary restrictions. I mean, man, nobody's going to take my chocolate away from me at the end of life. So diabetics actually really appreciate this time. There are no restrictions. So there's things that you can do for changes in appetite, but it may also be you've ruled all these things out, that they're simply at the point where the body says, I don't need it anymore. I don't want it anymore. And again, this is where the body's wisdom comes in. So I'll go back to that in a second. So back to Anna. The situation with her is the food that was being served to her in the assisted living home was not food that she was used to in her culture. So the family started to bring in other foods from home. She was missing her upper partial denture, so she couldn't even chew. And she was missing her family. So when they started to come in during some meal times and with their own foods, her appetite really picked up. So rule things out first. But again, if everything is ruled out, you may simply be at that point where the body says, enough already. I don't want to eat. I don't need to eat anymore. This is very often the time that sometimes families go, okay, you're not eating, but here's 40 supplements, right? Supplements do not take the place of food. And in fact, it doesn't do you a bit of good because you need a certain amount of food and fluid in your system to be able to even absorb the supplements. So it's not going to do you a bit of good. But have you guys taken, high doses of iron and supplements on an empty stomach? pretty nauseating, right? So you're kind of working against them. So I just tell families, forget supplements at the time that they're not eating, cancel the supplements too. We're also not going to stimulate the appetite, because what research has shown is that in end-stage disease, it does not reverse cachexia, meaning that severe weight loss with end-stage disease. It doesn't do that. What it does do is it may stimulate an appetite, but the body's at the point saying, I can't take all this food. And so they try and eat, and then they start cramping and throwing up. So that's not a good thing. So we just stay away from all of those interventions and just allow the person to say, this is what I can and can't eat. And that's okay with us. Because here's the body's wisdom. When you're not eating, actually it releases some endorphins, which is cool because it really helps your mood and also with pain control. And the cytokine also blocks the desire to eat and drink. So what it's also doing is it's blocking the storage of fat and protein. So even if I force fed you at this point, it wouldn't do a darn bit of good because it's being blocked. And the reason the body's doing this in its infinite wisdom is that it understands there's only one cell in the body that's going to continue to benefit from food at this point, and that's the cancer cell. And we try not to feed the pig. We had a young woman on our oncology floor. She was 42 and she had a tumor in her groin. And she was at that point of really losing a lot of weight, and we were worried about her. And they thought, well, you know, we need to bump her up for nutrition. So they gave her total nutrition through an IV, right? The next day, that tumor had tripled in size. We had fed the tumor. We had done nothing for her comfort. In fact, we had increased her discomfort. So again, we have to go back to honor the body's wisdom. It knows what it's doing. If they don't want to eat, we've ruled out the reversible things. It's okay to not eat. And recognize that emotionally, this is really, really tough on the family. Because this is how we show love, right? Eat, you'll feel better, right? So I might be frustrated. I'm caring for my mom going, okay, you're not eating, you're losing weight. I'll make my famous chocolate mousse cake because you love that. So I whip it up and I give it to her, and she eats this much of it, if at all. And it's not that she's rejected the mousse cake, it's that I feel rejected because I'm being reminded that I'm helpless and I can't change what's happening to her. And that's difficult to accept. So my frustration, I might just be saying, okay, just 4 more bites, Mom, 4 more bites of applesauce. Like it's going to do any good to reverse the disease, reverse what's going on, to eat 4 more bites of applesauce. But here's the risk. Mom might eat 4 more bites of applesauce, even if it makes her feel bad, because she can't afford to upset me as caregiver, because she might be afraid that I might withdraw my care. So we really look for that dynamic and recognize the fact that this is absolutely an emotionally laden topic for all family members. Sometimes they're also looking at, well, if they're not eating, let's do tube feedings. Well, there are places for tube feedings in healthcare, absolutely, but usually it's short-term and for recovery. But does the patient experience hunger and want that? And what's the disease status? If they're at end stage, you're going to see it's not going to be helpful. And what's the goal of care? Because the truth about tube feedings, that does not regain strength, does not prolong life, promote wound healing. In fact, it actually increases the mortality. It increases the chance of aspiration pneumonia, which is what we thought we were preventing in the first place. So let me explain why. If you go to an all-you-can-eat buffet, you can pig out all you want and eat and eat and eat. But there's one point at which your stomach is going to say, don't send anything else down here, or we're full, or we're going to send it back up, right? So you stop eating. Well, if you got a tube in your stomach just delivering ongoing fluid, you don't have the ability to say stop. And so that fluid might not be processed by the body. It's going to fill up the stomach, come up the esophagus, and then dump into the lungs. So they're more likely to get an aspiration pneumonia, an infection, as a result of tube feeding. So if you're dealing at end of life, it is absolutely not recommended according to all the research data. It's really important for families to understand too where the person is with the eating. We had a gentleman, we called him the general because he was in fact a general. He was 6'4", large, very intimidating. His wife was admitted, he admitted her with end stage multiple sclerosis. She could hardly transfer, she wasn't eating. And he was upset with her. They'd always had a really difficult relationship. And she was, in his mind, refusing to eat and get better. So he started to put demands on the staff saying, you got to keep forcing her to eat. You got to measure. I'm going to keep looking at all the logs, etc. Very intimidating. He didn't understand what was going on. And people were really frightened to actually tell him or confront him on it. It got so bad that he actually went to, and this woman had capacity, by the way. He wanted to have her to have a tube feeding, and she said no. So he went to a judge, declared her incapacitated because of being suicidal because she was refusing to eat. Well, he got awarded the right to demand that a tube feeding be inserted, unfortunately. And she had complications with that procedure and started to bleed. So she bled out. And while she was dying is when I first met him. And this big hunk of a man just crumpled in his chair. And he goes, I didn't know. He goes, I didn't know she couldn't eat. I thought she wouldn't eat. You know, we fought all our lives. I thought she wouldn't eat. And he was absolutely devastated that in the end, that he had pushed it and pushed discomfort at the end of life. That's a really hard memory to live with. So no matter where people come from, we have to find a way to sit down and just gently say, here's what's going on in the body. Here's what they can and can't do. And to provide the most comfort, here's what we recommend. Because if we're pushing food, we got to say, who are we really feeding? Are we feeding our guilt? Is it the need to appear to be doing something? Is it fear of litigation of a family saying we want tube feedings and, you know, our loved one's got dementia and they can't say no. We put it in because we don't want them to sue us. Or are we feeding that sense of helplessness? We feel like we're doing something. So we really have to look behind, if we're going to force feed something, what's the dynamic behind that? Again, if we're dealing with somebody in the terminal stages of an illness. So understand that when they're trying to feed their loved ones, they're just trying to do something nice to nurture. Give them something else to do. Comb their hair, listen to music, go through a photo album, foot massage, back massage. There's a lot we can do to nurture and nurture the body without putting pressure on forcing food. So finding some alternatives is really nice, a nice thing to do. Excuse me, let me get a sip of water here. Which is a good segue into dehydration. Okay, so it's bad enough they're not active, very, very active. Then they're not eating very much. And oh my God, now they're not drinking very much. Families are getting scared now because they know, again, that heralds that they're getting closer to the end. So there's a couple myths about dehydration. One is that it's uncomfortable. It is uncomfortable for us. If we got lost in the Catalina Mountains on a hike one day, you bet that would be miserable for us. But for people who are dealing with that progressive illness, the dehydration is actually very comfortable for them. And the body, again, is wise. They did a study on people who were called through natural dehydration. And what they did is that for half of them, they intervened and gave them intravenous fluids. And the other half, they just allowed them to be. And then they drew blood samples on both of them. They drew what we call electrolytes to kind of measure dehydration. The people they intervened on their blood work was completely out of whack. The people they allowed to be naturally dehydrated, their blood work was in perfect balance. So again, the body knows what it's doing. Allow them to do that, and it does create, that is comfortable, and it does also release some of those endorphins. Dry mouth does not equal thirst. It means a dry mouth. Thirst is not relieved with IV fluids. And that's illegal to stop food and fluids. Absolutely not. It is a medical intervention. There's always the right to say no. But here's the complication of artificial hydration. You start giving the body fluid it can't handle. You got increased secretions, incontinence, nausea, edema, shortness of breath. So what happens is, remember I said that heart's working pretty hard, you know, to get everything through the body. Well, there's a point at which the heart says, you know what, I just can't keep this up very well. So I'm going to start cutting circulation off to some areas because this is too difficult for me. But if you keep adding fluid, you're making the heart work harder and harder, and it doesn't have a place to put the fluid, and you start swelling. And you start swelling, you're more likely to get skin breakdown, I mean, all those sorts of things. So incontinence, all of those things are complications of artificial hydration at the end of life. But you allow them to naturally dehydrate, it means you got the release of endorphins, again, promoting that well-being and comfort. Less edema, less incontinence, less skin breakdown, less nausea, less ascites, less chest congestion. Awesome. The body will take care of it. And it's hard to understand because it's so different than who we are in regular life. But end of life or during the dying process is a whole nother ballgame. Now, you do need to consider, though, religious and cultural beliefs. So it might be that they feel that we have to have some hydration, but we know it's going to be taxing the patient's body. So it might be that we provide something really slow so that families can see that, oh, they're not doing better, they're actually doing worse with hydration. Yes, let's stop, you know, whatever. But the families may need to be able to see that because they just want the best for their loved ones. That's all. And they want to be able to feel like they did everything possible to enhance the life of their loved one. So I'm not going to judge them by that, but I'm going to sit with them very carefully to talk about what's happening, to observe and reinforce again what's going on with the body. Oh, I'm back on the dehydration part, and it's maybe also to the little eye thing. Sometimes patients will, their eyeballs will sink back into their head some, and their lids won't close. And I've had families wonder, are they giving me the evil eye? Are they looking at me? Have I made the wrong decision, etc.? What it is there's fat pads in the back of our eyeball. And when you get dehydrated, those fat pads start to shrink so the eyeball can fall back and then the lid may not shut all the way. So tell them you're not getting the evil eye. It's simply, you know, the impact of the dehydration. Okay.
Hey, Tawny.
Yeah.
Somebody asked, what does the initial AHN mean?
I'm sorry, artificial hydration and nutrition. Thank you. Thank you. So bowels and bladders, they don't stop until the body does. So yes, what will happen with natural dehydration is the bladder, the urine is going to get more concentrated. It's going to be a darker color. It may have a greater odor to it. That's natural. The bowels will continue to move, and it doesn't matter if they're not eating. Your body still produces waste. And a little bit of waste creates a little rock, and a little rock can wreak holy havoc in a body, and especially in the frail elderly. And that there's documentation of, with the elderly, that constipation actually creating what sounds like looks like a psychotic reaction to them. They get really agitated, and it's really just the constipation. So in hospice, we are big on bowels. You know, we want something every 3 days, or we're going to go in after that, because we want everything to continue to flow, and so it's optimizing comfort ultimately for the patient. So even if a family says, hey, they're barely eating anything, or they're just taking soup or whatever, it doesn't matter. They're still going to produce waste, and we still need to make sure it comes out. This is a biggie. If people have lung cancer, COPD, lung disease, they naturally are going to think, wow, I'm going to suffocate. You know, my breathing gets worse and worse over the year, and I'm going to be gasping for breath when I die. And that's a very frightening idea, and understandable, certainly. So that needs to be tended to pretty quickly about how we're going to manage the breathing of that. And again, this is part of the body's wisdom, is that when you're actively dying, your oxygen level starts to go down naturally. Your CO2 level starts to come up. Kind of that's the point that you go into the coma and you go to sleep. It's awesome. That's what takes care of it. But if you're in a hospital, very often we put those little oximeters, those little things on your fingers that measure your oxygen. So what do? When your oxygen level goes down because you're dying, it beeps. And you go, oh my God, we got to crank up the oxygen. You know, while the person's still trying to die, so eventually it's still going to go down, they're going to beep again, they crank up the oxygen again. After a while, it's not enough to get the regular oxygen tubing on. Now they put on a mask, which is very claustrophobic. And what we're doing is they're basically prolonging the dying process. So I just tell the families, look at the face. Look at the face. One is, if you've got a loved one who we know is dying in a hospital, do not let them put alarms, oximeters on them, because it's distracting and it's not necessary. Look at your loved one's face and look for any sign of distress or sign of peace, because that's what you're mainly going to see in those situations. So that's part of the body's wisdom as to how it's going to be changing. And as we're dying, the oxygen level is going to go low, low, low until it goes low enough that we actually die. Sometimes there's differences in breathing patterns, and that depends on the particular disease that somebody has. So it may be, rapid shallow breaths. It may be periodic, deep sighing breaths. Or it may be what we call Shane Stokes breathing, which is irregular breathing, which means they start breathing slower and then slower and then slower, and then they start picking up again, and it makes the family go, whoa. It's just what's going on chemically in the body. I just, again, tell the family to look at their patient's face. Their biggest concern is that somebody is suffering, and you can see by the face that they are not. If there are any issues on breathing, I mean, there's certainly medications that we can use, especially with somebody who has COPD, et cetera, to help with breathing and relaxation. It works beautifully. But the breathing patterns may change, and not to be too distressed about that. What is distressing, which we don't have a really good answer for all the time, is the death rattle. What that is that the point at which you are getting much closer to death, you start losing your swallow reflex. And so you start collecting moisture on top of your larynx. Even just breathing the air, there's moisture in the air, and that will start collecting on your larynx. So when you start breathing, it starts to bubble, and it may sound like a nasty snore or wet, gurgly sound. It's very distressing to hear, absolutely no doubt about it. You can try and reposition the person to their side, put the head up, etc. We don't suction because that's invasive and it will come back. We can give something we call atropine to draw out the secretion. Sometimes that works. Sometimes it just doesn't work, and it's just noisy, difficult. When somebody is having the death rattle, they're usually comatose. So again, it's the family who's present that's suffering with that. So what I usually recommend is use sound over the death rattle. Get them talking, get them telling stories, get them singing, turn on TV, whatever it is, but use noise to overcome the death rattle noise itself, because just acknowledge that is difficult to hear. But again, the patient is usually non-responsive by the time that sort of thing happens. And again, look at the face. They're usually very calm, very comfortable. Circulation. Okay, so again, not all of these happen with everybody. I'm giving you some general things, but sometimes there'll be a change in circulation, especially like with, for example, some heart disease, et cetera, whereby the heart is saying, you know what, I'm getting really tired here. I have got to keep the blood going to the brain, the lungs, and the liver. But, arms and legs, you're not so important. So I'm cutting you off, basically, because I can't do it all, right? I'm working too hard. So now the arms and legs get cold. So now we feel the arms and legs cold, and we go, oh my God, they're so cold, we got to cover them up with a blanket. Well, even in a coma, very often they kick that blanket off because, in fact, they're hot. In fact, their blood is being concentrated in this area, and they may even have a fever. So again, let the patient be the expert. If they only want a light sheet or no coverage at all, that's okay. That's about their comfort level. As the dying progresses, the heart rate will go faster, trying to keep up, and it will get thready and irregular. The blood pressure will start going down, and then the heart rate will start going down and irregular until finally to a stop. But again, not in all circumstances. Agitation. Sometimes you've got somebody who's actively dying and suddenly they get really agitated and you don't know what's going on. The most common explanation first, go for that, but everybody who's listening in has experienced, and that is full bladder. You don't feel good if you've got a full bladder, you really need to go, right? But they can't tell you that. So, make sure that they've been peeing or put a catheter or whatever to make sure that the bladder, the bowels are still working, because that's probably the number one cause of agitation. After that, you're going to have to do some sleuthing. I had a friend, she was a healing touch practitioner. We had a gentleman on the unit who suddenly got really agitated. And we thought it was pain, and we kept giving him all this pain medication. And the hospital was about to run out of this particular med. It's like, it wasn't touching the guy. So she came in with the permission of the family, and she, kind of scanned him with her healing touch, and she picked up a lot of fear kind of around his belly. And she did an unruffling technique, I think is what she called it, to kind of even that out. And within about 10 minutes, he really settled down. And then within an hour, he had died. So there's a lot of different ways that we can approach that. But knowing the person's history, I think, is also really important. I was admitting a gentleman to the hospice home care, and I was at his home, and I didn't know anything about him coming in. All I knew was that his son and daughters were in from out of town. He had a Spanish-speaking caregiver. He had Yiddish paraphernalia in the corner of his room, and he was not able to communicate, and he started getting agitated. Well, we were just doing the admission, so I had no tools for which to handle agitation. So I'm looking around thinking, well, what do you do? Music, I thought music of the childhood, maybe that would be helpful. So we put on some Yiddish music, and the agitation grew worse, and it turned into a cry. And it was that cry of a child being separated from his mother, or mother from a child. It just shot through us. And I just stopped everything. And I said, whoa, wait a minute. Tell me this guy's history. Well, only the son knew this. Apparently this gentleman was in the war in Poland during the Holocaust. And he was being snuck out at midnight at the age of 15. And his mother refused to come with him. And he was banging on the door for her to come. And she would refuse to answer the door. And he was banging and banging and crying and banging. And she refused to answer. And we thought, oh my gosh, this is that cry. This is the cry. It's the memory from the past. So now what do you do, right? Well, apparently from Poland, he escaped, he went to Mexico, and that's where he felt safe. So we then put on some Mexican music so that, and actually it did settle him down until such time that we had, other tools to avail. So to have somebody's history is important, especially if they've had any PTSD, sexual abuse, physical abuse, war, etc. If it hasn't been taken care of during their lifetime or processed out, it may come back to bite them at this point. So finding ways of being able to access that is really important. And there's energy surges. This sometimes is called the Lazarus syndrome. This is when somebody's actively dying, they're in their coma, they're on their way, and suddenly they wake up and they're talking to you, and you go, whoa, it's a miracle. Well, probably not. They're probably going to be short term. Why that happens, how that happens, don't know. But it seems to be a wonderful piece of closure for some folks. We had my friend Joan, her mother-in-law had dementia and hadn't recognized anybody in 2 years. And she was actively dying, and they were at the bedside. And suddenly she did that. She woke up, she looked at her son, she called him by his pet name, said, I love you. She looked to Joan and said, thank you. And then she was gone again, and then she died. There's a woman in Sicily who I'd heard about who had been in a vegetative state for 6 years, total care, total feed, total everything, non-communicative, etc. Now she's actively dying. The family is gathered in the room, and she does the same thing. She wakes up and she's talking, to people around the ceiling. And the family goes, well, we don't get, why are you talking to people there? And she goes, well, we don't see anyone. And she goes, well, yeah, you don't see them because they've come for me. They haven't come for you. And he goes, well, Grandma, you've been like a vegetable for 6 years. What? And she said, but the places I've been. So I think that's one of the wonderful mysteries of the things that we don't know of. We can look at somebody who's got severe dementia or stroke or whatever and think, oh, how sad and awful, but they may be having a heck of a life in there. But no matter what, they are still fully intact human beings worthy of absolutely the best care and interaction as if they were totally coherent. So I think these little incidences are just to remind us that that person is still in there. And sometimes they can come out to say something that is awesome. What a treat that is. How, why, I have no idea. But what a blessing that is for people. Okay, let me get into some communication issues then. That the only thing harder than talking about dying is not talking about it. It's how do you get closure? How do you get people, when people are dying, to talk about that? Excuse me, get some more water. So facilitating that communication is important. Some people need to be let go of. We were caring for a woman, and she had kidney cancer, and she was actively dying. And she had a son and her daughter, and her husband, who all knew that she was not going to leave the hospital. And she just kept holding on and holding on. We're thinking, how is this lady still alive? Well, I finally was overheard the son and the daughter on either side of her holding her hands. And they were saying, Mom, you're going to get better. We're going to get you stronger. We're going to get you home. We're going to take that trip to Hawaii. Mom heard, they're not ready to let me go yet. So she was holding on with it for all her life. So I shared what I observed with the husband. And then he took the kids to the side and talked with them too. And they came back a little bit later, and they came back and held their mom's hand again. And they said, Mom, we love you. We'll miss you. And we'll be okay. In 10 minutes, she died. Some people need to get released. So finding out what holds people on is really important. Do they have a spouse who has Alzheimer's and they don't know who's going to care for them? Do they have 30 cats at home that they need placement for? Or I always said that with my mom, she wasn't going to die until I found a husband. I was going to have to fake a marriage just so she could let go. I'm like, oh, for God's sakes. So find out what that is to help them feel like it's okay for them to go now. Now, if you want to say it's okay to go, that's all right, but just say it once. Because I'll have the family say, you know, okay, Grandma, you can go now. And day 2. Grandma, we said you could go now. Day 3. Grandma, you can go now. Grandpa's upstairs. He's waiting for you. And I said, okay, you know what? 3 things need to happen. Grandma, you need to let go of Grandma. Cool, you did. Grandma needs to let go of you. And then 3rd, Grandma's body needs to let go of her. So if you want to say let go, just say it once, please. Just don't kick him out. Now, being able to do closure is really nice, but if people have been a nasty SOB in life, chances are very good there's still going to be that in their dying process. So that the son who's waited 50 years for dad to suddenly say, I'm sorry and I love you, may not get that. And that's why we want the good bereavement groups. But closure, when we can get it, is really, really very nice, but it may not be pretty, but it's still important. We had a gentleman who came to the unit. He was 82 and he was close to dying. And he just said, I need to see my daughter. And so we didn't know the family, and we called the daughter and we said, you know, your father wants to see you. And she says, no, I'm not coming in. He's just holding on again, another day, holding on. I need to see my daughter. I need to see my daughter. We called her again. We said, we think this is the only reason your father's still hanging on to life. Is there any chance you can come in? And very begrudgingly, she did. She walked into the unit. She walked into his room. She walked over to the bed and looked down at the old man in the bed. And she said, now I'm going to quote her, so please excuse my language. She said, you no good son of a bitch. You sexually molested me the first 14 years of my life. As a result, I've had 30 years of counseling. I will never have a normal relationship with a man, and I hope you rot in hell. With that, she turned and she left. But he relaxed. Within about 2 hours, he had died. So was that pretty closure? No. But it was the first time she'd ever faced him as a perpetrator. And he wanted to give her the chance to be able to do that. So it may not be pretty, but any kind of closure that you can get done, there are no do-overs, you know, we get it done. Now we'll get into the mystery, which I love. Let me take a look at the time. Oh, God, I'm hurting. Okay, the most beautiful thing we can experience is the mysterious. So the timing of death, I love this. I always let families know ahead of time. If you're supposed to be there, you will. If you're not supposed to be there, you won't. Do not put a judgment on whether you were there or not. You were good because you were there, you were bad because you weren't. It doesn't matter. Your relationship, your time with this person is not measured by those last minutes. It's whatever it needed to happen. Find some meaning. And if you let them know ahead of time, they can find some meaning in that timing also. We had a gentleman or a woman who was admitted to the unit, and she was going to die on that admission. But she had one wish, and that was to be divorced. And because what happened is when she got sick, her husband shacked up with a younger woman. She wanted to make sure her assets went to her daughter, not her cheating husband. So the divorce hearing was supposed to be at 1 o'clock on Monday morning. As long as she was alive at 1 o'clock on Monday morning, she got her wish. Okay, well, it's Friday afternoon. So we were trying to honor the dying process, but by God, we're going to keep her alive till 1 o'clock on Monday morning, because now we're all kind of on board with their wishes, right? Well, she started to decline over the weekend, and we're like, oh, please, Monday at 1, that's all we need. Monday morning at 11:05, she died, and we were devastated. And we called the daughter and we said, we are so sorry your mom didn't get her wish. And she said, well, what are you talking about? And she goes, well, the divorce hearing at 1:00 today. And she goes, oh, I hadn't told anybody. I had it moved up to 11. So there was that knowing. So she did, in fact, get her wish. So the timing is remarkable, and people can find meaning in that. And so it takes away this thing when they go, okay, how did this happen? There's times where I've had families have to leave because they weren't about to let the guy die. They weren't about to let him die because they kept saying, Dad, you're with us. We had to shoo him out of the room so that the gentleman could actually die on his own just for a couple minutes. I was pronouncing the death on South Tucson of a woman whose only wish was to get her son home from Iraq. This was during the war there, always a war there. And we were having a really hard time getting him released from the army. We weren't sure he was going to make it back in time, but he finally got released. And the plane landed on the tarmac. So he whipped open his cell phone. He called home. His father put the phone up to his mother's ear and he said, Mom, I'm home. I'm on the ground. I'll be home in 20 minutes. And she whispered, I love you. And just 2 minutes later, she died. And when I heard that, I just said, oh, I'm so sorry you didn't make it. And he goes, oh, no. He goes, my mom knew me. I would have had a really hard time watching that last breath. But to have heard her sweet voice and to see her in beautiful repose, he goes, that was perfect. So she got her wish. Her son was home. He was safe on the ground. And he got his wish to see her mom be comfortable. So look at the timing. Prepare them for that. And it's the unknown for us. I'll have families say, we're on the unit and going, we've been here all morning and we're really hungry. And do you think we have time to go get lunch? I don't know. So again, assume hearing is the last to go. Timing is set. Tell your dad who's in the coma there, Dad, we're going to go for lunch. We'll be back in 45 minutes, and then just let it be. He knows he's got 45 minutes to either die, get out of there, or I'll have to wait at least another 45 minutes to interact with you. But let it go. There is no judgment or need to be there, because sometimes people just don't want anybody around. Then there's the idea of visions. Now, I didn't used to believe in visions, but again, my patients have been phenomenal teachers. And it doesn't matter if you don't believe in visions at all. It really doesn't. What does matter, though, if the person that you're caring for is having a vision, it means something to them. So it really behooves you to get to learn from them, to say, what are you seeing? What does it mean to you? They'll give you a little glimpse into their own little mystery. I never call it hallucination unless it's black bugs or spiders, because that's sometimes specific to a problem with the narcotics, and we usually just change the drug. But anything else, just because I can't see it doesn't mean it's not there. And I'm going to have the patient tell me what they can about it when they're able to. My friend Joan was attending the dying of a young man. He was only 27, and he was able to talk to very close to his death. And they had surrounded his bed at home. And he looked at the end of the bed and he said, "Who's that little boy at the end of my bed?" Well, no one else saw a little boy, so he described him. He said, little 3-year-old, maybe blonde boy. Mother went running out of the room. She came back again with a picture a couple minutes later with a little with a little blonde boy. She showed it to her dying son, and he said, "Yeah, that's him. How did you get his picture?" She never told him that he had a brother who had died before he was born, and that was him. So in the midst of the pain of losing another son, there was that comfort of, wow, they're together. Maybe I'll see them someday. So what a gift it is when they are able to share some of those visions. And my patients have taught me so much about that. I had a lady who was really cantankerous at home. I was the only person who was allowed to visit her, and very begrudgingly, but that was the only way she could remain at home by herself. And she had no belief system. When you're dead, that's it. She didn't have any friends. They were dead. She got rid of that no good husband of hers years before. Thank God he was dead. her family, she didn't like them, but they were dead. She was glad. So then but she had a son and her daughter. Now the daughter had wanted to become a nun, but she had some politics going on and had her own faith crisis happening and wasn't able to achieve that goal. But the daughter and I did talk about the dying process and the possibility of visions. The patient never wanted to talk about it, which is fine. So one day, the lady was getting her wish of dying quickly. I knew she was declining quickly. I called the daughter, I got her into bed, and she's lying in her bed and she's talking semi-comatose through her dying. I've never seen that before. Now, people who are dying very often talk in symbolic or metaphoric language. And probably the most common thing you'll hear is, I want to go home. It doesn't matter if they're home or not. They may be talking another home, or they're talking about journeys or transport, or where's my wedding dress, because they're going to join their husband who's died before them. So I say, listen with a third ear to see what you can find meaning. So this lady was lying here and she was saying, where's the bus? The bus is late. Oh, okay, I got it. Because we used to use that term in hospice. So I'm not sure how to interact with it. So I said, well, the bus is coming. And then I got a little braver and I said, and family members will be on it to help you. And she goes, oh, goody. Like, oh yeah, she hated her family. So I shut up again for a while. And she said, where's the bus? The bus is late. Well, after a while, she reported a bus showed up. Silence for a while. And then she said, I can't stay on this bus. This is the bus to hell. I didn't know what to say. So I said, well, get off the bus. I didn't, but apparently that worked because she got off the bus. Then we're back to, where's the bus? The bus is late. Well, after a long while, she reported a white ambulance showed up. And I asked if that was okay. And she goes, yes. Okay. Silence again for a long time. Then everything in that room changed. Her body lit up with joy I had never seen. Her hands came up to her face. She was grinning ear to ear. And Lord knows I never saw this woman smile. And she said, look, there's a party. And they've been waiting for me all this time. And yes, I did find out it was her friends at the party, not her family. So she was ecstatic. The daughter's across from me and tears are streaming down her face. And she said, I know you said this was possible, but until this moment, I didn't believe it. So here's a woman with no belief or faith tradition who, in sharing her visions and dying, reaffirms the faith of her daughter and gives me a glimpse yet again into, wow, this is really cool. So when I was married and my own mother-in-law was dying, she was, we did talk about the dying process. We talked about visions, and I was wondering if she was going to see her father or her brother who had died before her. And, she was very active in her church. And when she got close to the end, she got admitted to the inpatient unit for symptom control. She climbed into bed. She looked at the end of the bed and she said, what is that duck doing at the end of my bed? Well, of course, I saw no duck at the end of the bed. I was hoping for a little more grandiose vision, but, use it. They can control the visions. I said, well, tell the duck to go away. She shooed the duck away to the corner of the room and stayed there, but it was okay. Day 2, that duck showed up again. That duck irritated her again. So she shooed the duck away, go to the corner of the room. It was okay. Day 3, that duck showed up again. But that day it didn't bother her. And that was the day that she died. If you've ever been with somebody who's like, they're dying like right now, there just happened to be this chaplain coming by, grabbed him by the arm, family circled around her, held hands, said the Lord's Prayer for her wish. She waited for the amen and she died. And it's like, okay, that was pretty classy, Rosie, kind of something I would expect from you. Cool. Now, in the meantime, my middle son was going through a really bad time of his life, and he adored his grandmother, and she adored him. But he was being sent to a wilderness camp on the border of Idaho and Canada in the dead of winter. And he knew he would not be here when she died. And he was devastated. I said, Justin, I know she'll get word to you. She'll check on you when she dies because you're too important to her. So when she died, I typed up a little thing about her dying. I didn't say anything about the duck, and I faxed it to the camp counselor because it's the day before email. And then I got a fax letter back the next day, and they said, we took your letter and your son to a top of a high snowy knoll, again, dead of winter, border Canada, right? And as we read the letter, a single duck flew by and started to circle our heads. I said, oh, there's the connection, the duck. I had to tell him about the duck. Okay, so I did that. Still hadn't told anybody else. I don't know why. So now we're at the church service, and my brother reaches over and he puts a fetish bag in my hand, and I open it up, and it's a duck. I said, why did you give me a duck fetish? And he goes, well, in the Zuni tradition, it's the duck that carries the spirit into the next world. So it's not as though I needed more affirmation at that point. But again, it's just to say, you know what, there's so much that goes on that we don't know. Isn't it awesome though? And so if you can be open to some of the mysteries, it doesn't take away the pain of the death, but it really expands our awareness of what's going on. So if I've got somebody maybe who's dying, you know, I might kind of help them also appreciate the fact that they may be having visions. Who are you looking forward to seeing? You know, is it your husband? Is it your children? Is it, you know, your sister? Is there anyone with them now? That's cool to know. Sometimes when I've been desperate, I've just called out to whomever to say, hey guys, we need some help here, you know, help with transition easily. But be the student. Be the student, because if you're really working with the dying, they will give you all kinds of glimpses into what this huge mystery is, which is awesome. So again, what we can and can't do is we can prepare them so it's not fearful. We can give them the tools to empower them to provide the best care. Can we take away the pain? Absolutely not. But we can take away the extra sting of not knowing and of not being prepared. And if we can open them to the mystery too, then that really enhances our own life. So in honor of those who've gone before us, and in tribute to those who remain to teach us, and an appreciation for the eternal gift of the human spirit. To me, again, these are my patients, these are my teachers, and I am so appreciative and continue to be appreciative of them. So if we can manage the dying process, a good death does honor to a whole life. And that to me is what that goal is. So I guess we'll open it up to questions, because I know that there's not a lot I didn't cover because I covered more general aspects, but
Yeah, thank you so much, Tani. Jen, are people able to unmute themselves and ask questions of Tani? Okay, and maybe Tani, do you mind if we stop the video so we can see everybody?
Yeah.
In case people are raising their hands and such.
Yeah, let's just get rid of this. Where are you?
Let's see. Okay, so I see in the chat. Oh, Desmond, so moving and amazing, Tani. Thank you. Agreed. Feel free to just unmute and ask, or if you want to raise a hand, whatever feels good to you.
I wanted to ask, you referred to it a little bit, but maybe more detail. How do you know if the person is in pain or needs more pain meds at that last stage?
I'm going to look at what their history is going up to that stage. And I'm glad you're asking about the pain medication. If somebody has needed a certain amount of pain medication to keep them comfortable before they go under the coma, I am more likely to keep that same dosage going, because pain will actually interfere with the dying process. If you stop the pain medication and the pain returns, it's going to be really much harder to die. You're going to have to get them back under control again. So I just keep them with the same level of pain control that I can. So hopefully you've achieved good pain control before they get to that part. If you're not sure, sometimes you're playing a little guessing game. You know, what do you know about them, what they're grimacing or wincing, but it could just be that they're uncomfortable or they need a massage or something else. So sometimes you have to do a little bit of sleuthing with that. Yeah.
I wondered if you have like a cheat sheet of all of these, so like the symptoms and then like what your recommendation potentially is, so that if you're in the situation, I think sometimes it's hard to remember all these different pieces. If you had like a little cheat sheet, you could say, oh, when they're doing this, it might mean this, or
Right. I think
you,
that's, yeah, I don't have a cheat sheet per se. I have, I did a book on it. I did the DVD on it.
oh, okay.
But the book is little tiny segments, so you can flip to whatever chapter you want. So it's just very simply written. So that might be the easiest thing, is to say, oh, it's about breathing now. Let me look up this one and see what I need to do.
And is that on a particular site, or is that like print to
Um,
print to buy?
I think that's on my website, pathwayseol.com.
Okay, great. Thank you.
Mhm.
Just drop that in the chat, pathwayseol.com. Yeah. Any other questions for Tani or comments about what we learned together tonight?
Is there anything about the physical experiences or appearances to prepare families to, to see, that might be otherwise frightening if you didn't? I just remember when my parents were in hospice, they explained about the extremities actually getting black, that was something to expect. And a friend of mine whose husband just died, at the very end, he kind of like just ejected a lot of fluid and blood. So kind of some of those things that can be really, pretty awful if you haven't been through it before. Is there anything that in that light?
Yeah, it's a little unpredictable. When you actually die, everything loosens up your sphincters, which is why you lose bowel and urine, and sometimes the throwing up if you've been holding down. We don't always know that that's going to happen, and thankfully it doesn't happen very often. But it's a good question, because I don't usually prepare people for that, because I don't see it very often. But if it happens, then I can respond to it usually right away. But otherwise, just letting them know physically what's happening in the cold extremities and the eyeballs and all that good stuff. Yeah.
Okay.
Well, Tani, thank you so much. We are so grateful for your wisdom, and hopefully you have a chance to look in the chat, because there are a lot of lovely comments just about how meaningful this has been. These last two sessions have been phenomenal. So thank you so much. And Jen, I think we have probably a few things. I know we've started doing, yes. We're going to launch a survey, just because we always try to keep improving. So if there are things we can do differently. Next month is National Caregivers Month. And in honor of that, we have Karen Kochar, who owns Right at Home caregiving services, and she will be with us to talk all things about caregiving and answer questions from her perspective. We would love for you to join us for that. And then, as is tradition, we take December off, because most everybody's pulling their hair out, getting ready for the holidays or finishing up their holidays. We have some community events that we want to share. Let's see. All right. So, and some of you have talked, I don't know if this is what you're talking about, but medical aid in dying is not legal here in the state of Arizona, but there is a group which is putting on, and they do a lot of events just trying to educate people about what might be an option if we're able to be legal here. So they're having an event on Sunday the 29th from 2 to 4 at the Loft. It's free and open to the public if you would like to learn more from them. What else? Oh, yes. So we are teaming up with Raíces Taller, which is a local art, not museum, an art studio. And they do a Dia de los Muertos. They're going to build an ofrenda, which is like that offering, the altar. So we'll do that on Dia de los Muertos itself. It'll start with a blessing. We'll have food. We would love to see you there at 6 to 9 p.m. On the 2nd, and it's kind of downtown near 6th and 6th. But we also have, do we have the one about on the 11th, Jen, or do we not have the details for that yet? Okay, we're doing another project with them a couple of weeks later around grief. And we're really moving quite a bit into the grief arena. As a matter of fact, our 2024 education series will be all about grief, kicking off with Dr. Joanna Cacciatore, including folks like, oh, Jen, I'm blanking on his name, the Ken Doka, who does a lot about how grief somatically affects our bodies, right? So we're really excited about next year and hope that you join us for that as well. Is there any other thing? Oh, yes. And also, we're just a co-sponsor of this, the Neurobiology Grief International Network, which they call for short Noggin, which is super cute. They are doing a celebration of Dr. Kathy Shear. So that is free and open to the public. Again, we're co-sponsoring that with the U of A School of Psychology. And what else? Oh, yes, of course. Thank you, thank you, thank you to all of you who support us financially with gifts, whether it's for our patient fund assistance, for our educational efforts, for the crosswalk. But there are a lot of other ways to support us as well. Every time you shop at Walmart, when you, fries. So here are just some of the ways that if you're going to shop anyhow, you can, a bit of that can come to us to support the folks that we support at End of Life. And I think that's it. Thank you again, Tawny, so much for sharing your wisdom, your experiences, your stories. I loved how everything was, as you said, your patients have been your teachers. And so really so grateful for you sharing those tender moments. And thank all of you for being with us. And we hope to see you in November.